Hi, this is Brian Kim. I'm going to share with you this case of a patient who has referred to me for a dislocated IOL. I'm going to perform a Goretex scleral suture technique, which is a minimally invasive small incision approach. Every dislocated IOL case is different. Sometimes you have to do a removal, an exchange technique, Yamane, vitrectomy. There are a variety of ways to deal with the dislocated IOL. And in this particular case, you'll see my thought process on why I chose to keep the lens and do this small incision, minimally invasive Goretex scleral suture technique. So you can see this is a patient's eye. You can see this is a three-piece lens, and one of the haptics is actually sticking into the anterior chamber. Now, mind you, this eye has been stable for many, many years. And so this tells me that there's some level of sulcus support. I believe this lens is in the sulcus, but it's an unstable sulcus. And so in this situation, I feel like saving the lens makes sense. If there's a little bit of support, all you really need to do is provide some extra support by lassoing the suture. And I do feel this is really kind of the easiest, least risky, and least invasive way to stabilize this lens. So you can see I'm making my peritomy, and I make a relaxing incision on one side, and I do the same exact thing on the other side. And you want to make sure you get all the way down to the sclera, remove any Tenon's tissue. And you want to have good exposure with this, so when you make your relaxing incision, don't be shy. Even though it's a larger incision, you just need to make sure you have a good visibility of your scleral groove. Now I'm performing some cautery, making sure I cauterize over the edge of the groove, because when you make the groove, it might bleed. And so now I'm making my limbal marks, making sure both marks are 180 degrees apart. And this is important to make sure that the lens is going to be well centered. I go 2 millimeters posterior to the limbus. You can see I'm using the caliper, indenting the sclera, again, 2 millimeters posterior to the limbal marks there. Once I make my marks, I'll go back and using ink pen just to reinforce the visibility of my mark. And then this is the partial thickness scleral groove. Again, I'm 2 millimeters back, and I'm going basically around 3 millimeters in length of my scleral groove. Again, I'm parallel to the limbus. So partial thickness scleral groove using my diamond blade, and then I make stab incisions into the sclera on each end of the scleral groove. And I do the same technique on the other side. Again, a partial thickness scleral groove, stabbing into the sclera full thickness on either end of the scleral groove. And this is something I've done differently. I've had trouble with visualizing my lasso, making sure I'm around the haptic sometimes, and I'd wonder if I was really around it. And so this is going to be like my adaptation, my belt and suspenders way of doing the lasso. And I'm going to make stab incisions in the iris, and I'm going to place iris hooks right over the area that I'm working. Because if I place the iris hooks in these areas, you can see my McPherson forceps were bent, so I had to switch it out. But I'm going to go ahead and retract the iris over the area that I'm working. And this will ensure that I'm definitely over and under the haptic when I do the lasso technique. I make my supratemporal incision with my diamond blade. And this is my Goretex. This is a CV8 suture. I'm going to use 2 micro forceps going in through one of the grooves, the far side of the groove on the left side there, and then I'm taking the suture and going through my supratemporal incision. I'm getting underneath the haptic with the forceps, and I'm handshaking the suture off. And so you can see the suture is now underneath the haptic. I'm injecting some cohesive viscoelastic to create some more space, and it pushes the haptic back. And this helps me ensure that I'm definitely over the haptic for this second suture pass. So you can see I'm through the scleral groove on the near side, on the other side, making sure I'm over the haptic. And then through the supratemporal incision, I do a handshake maneuver from one microforcep to the other, and you can see now I have effectively lassoed that haptic. Now I'm going to do the same exact thing with the iris hooks on the right side now, and I'm going to essentially perform the same exact technique on the right side. Again, I've never seen anyone using iris hooks to retract the iris in order to visualize the lasso. But for me, I feel like I want to be able to see it to make sure that I'm definitely over and under the haptic with the suture. And this gives me a lot more confidence that I did the procedure correctly. So now I have the iris hooks in place. I go in to the scleral incision with the microforceps, and I'm making sure I'm under the haptic on the near side here. I go through the supratemporal incision with the Goretex suture in the forceps, and I handshake the suture and I externalize it through the scleral incision. Again, on this side, the suture is going under the haptic. I'm injecting some more cohesive viscoelastic to push the haptic back. And then on the far side, the scleral incision, I'm going to enter. And I turn parallel fairly quickly, hoping that I'm definitely over the haptic. That's my hope, that I'm over the haptic. Go through the supratemporal incision, handshake off the suture, and then pull it out through the sclerotomy there. As I pull the sutures, I should see the lens wobble a little bit from the tension on the haptic. Unlike the left side, you can see here the haptic doesn't move. And so that makes me a little bit concerned that I didn't really get the suture around the haptic. And so this is a Maltzman. I'm going to take the Maltzman and I'm going to go and retract the iris. And as I retract the iris, you can see right there, the haptic is actually over the suture. So again, the suture actually went under the haptic on both passes. And that's why I didn't secure the haptic, and it did not effectively lasso the haptic with the Goretex suture. So what you're seeing here, I'm trying to pull the distal suture inside the eye and going to pull it back out because it did not get around the haptic effectively. So I go back, try again, and once I'm in place, I'm actually going to place the Maltzman in, retract the iris edge, and as I do this, you'll see that the forcep is definitely over the haptic. And so I confirm that the forcep is definitely over the haptic. Again, the other suture is definitely under the haptic. I handshake the suture through the supratemporal incision, handshake the suture, pull it through the sclerotomy, and again, this one is over the haptic, and so this should effectively lasso. As I pull the suture, notice the little wobble of the lens right there, that's right. So the wobble of the lens tells you that I'm around the haptic with the suture. And just because I'm a little paranoid, I go back under and I see, and definitely that haptic is under that suture. Or in other words, that suture is over that haptic right there. This is a key with Goretex. If you pull it too tight, it won't easily loosen. And so you want to do a single throw and you want to keep it fairly loose on either side. And this is kind of the most tedious part because what you want to do is try to move fast because you feel like, oh, this is the easy part. But the truth is, this is the hard part, because if you mess this up, you have to start all over. If you accidentally pull that suture, it will slip off of the haptic. And if you do that, then it's worthless. And so you just provide a little bit of tension. And again, you're not using the suture to strongly fixate the haptic because, there's a loop there. All you're doing is providing a little bit of support. And so once you've taken out the slack, you do single throws, and on the third and fourth throw, you can really, really tighten it down, and it locks the suture into place. And it's very important to bury the knot. If you don't bury the knot, you can have erosion of the conjunctiva, and it has an increased risk for infection. As long as you bury the knot, this should not happen. You can see here I'm just gently teasing that lens over to the right because it looks like it's a little discentered. But I think this is what's going on. The eye is actually tilted down, so it looks a little bit off-centered, but it's not. So go ahead and lock the other side now with additional single throws. And with each successive throw, I'm actually applying more tightening force, and it won't cause the knot to move, and it locks the knot in place. So I go ahead and cut the ends here, and then I'm going to bury this knot as well through the sclerotomy. You don't want to ever thread the Goretex through a needle and pull it through the sclera without making an incision like I did. Because with the incision, I'm able to place microforceps very easily, and I'm able to bury the knot very easily. If you just made a stab with a needle and you try to dock another needle and pull it through, you're not going to be able to bury the knot that easily. So making a scleral incision is very important. I take out the iris hooks. And I start to hydrate my incision, and I'm burping some of that cohesive viscoelastic. As you can see here, this was a closed system, minimally invasive through small incisions. I didn't have to cut the lens out. I didn't have to do a vitrectomy. There's no vitreous in the anterior chamber. Again, through a closed system, I was in a very controlled way, was able to lasso the Goretex suture around the haptics. In order to make sure I'm really, really clean, I injected some intracameral myocol, which constricted the pupil, and then I'm going in with the Retractor, and I'm essentially performing INA with the Retractor, but just wanting to make sure there's no vitreous in the anterior chamber. And I did not see any evidence for vitreous in the anterior chamber, and the myocol being small and round confirms that as well. So at the end here, I hydrate my incisions. I'll go ahead and close the epidermis with adovicral suture, and then I'll inject some intracameral lidocaine and Ancef at the end of the case. So again, this is a minimally invasive technique. I didn't have to do a vitrectomy. I saw that the lens was dislocated. This patient had a fairly stable lens for many years, and it's a late dislocation, which again tells me that the patient had some level of sulcus support. And when I retracted the edges, I did see some anterior capsule edge there. And so when there's some level of support, you can do this suture technique. When you're performing the suture lasso technique, you're providing some level of support for the haptics on either side. This is not the situation where you have zero bag and a full vitrectomized eye. In those situations, you really, really need to have a solid and stable scleral supported lens like a Yamane technique or a glued IOL technique. You could even do the acryos technique or use the Invista lens. But the point is you'd have to have a lot more robust support because there is a potential for late slippage if you don't have solid support. This patient had a lens that was in place for a long time, late dislocation. Again, the patient has some level of support, and you're just trying to provide some extra support. And the Goretex lasso technique through scleral incisions is really very helpful. I'm able to place the suture through the groove. You want to bury the knots again through the scleral stab incisions. You want to make sure the sutures are relatively loose, but all the slack is removed. As you pull the suture ends, you should see the implant moving towards the suture as you're pulling it. That indicates that you've captured the lens. You do that on either side. If there's any indication that you might not be completely around the lens, you have to retract the iris and visualize it. You saw with this technique, this is the first time that I've seen it done this way, and this is the first time I've done it this way, by using iris hooks to retract the edge. By retracting the iris edge, I was able to see a lot more clearly and confidently, making sure that the suture was indeed lassoed around the haptics. I did this on either side. Again, on the right side, I actually missed and I wasn't around it. And it was because I used the iris hooks to retract it, and I used the Maltzman to make sure the pupil edge was completely retracted, and I was able to start all over again. So I hope this was helpful to you, and I thank you for your attention.